Wonderful. Thank you. Okay. So it's my pleasure to be part of this session to talk a little bit about how we can be leveraging digital technologies to help us with translating our guidelines and going through two examples of some of our current work. These are my disclosures. So the objective I have for the next 15 minutes is try to help explain a little bit about how we can use we can create effective and inclusive interventions in order to help with translating our therapeutic dietary patterns to help put them into practice. And this is where we're leveraging digital technologies as well as co-design and behavior change frameworks. So the overall goal here is to examine approaches to knowledge translation and implementation for real-world application. So a big challenge we face is that there's a lot of discordant messages that are facing the public, and that can result in a lot of confusion, following things that are not evidence-based, and even potentially result in distrust in the scientific community. So there really is a need to help with disentangling discrepancies, not only to help drive our guidelines and to get that knowledge that we know about what diet works to help with mitigating chronic disease, but also to help support public uptake. So our evidence-based dietary patterns are presented fairly consistently across clinical practice guidelines for obesity, diabetes, cardiovascular disease. The example I have in the background there is for Diabetes Canada, but they're similar across within our DNSG ASD guidelines. So these include vegetarian, DASH, Mediterranean, portfolio, and low GI. But again, like I mentioned, the challenge we face is how we're supporting translation of that into the real world. So with the thought of thinking about whether or not we can leverage digital technology because it is a medium through which we can really help engage a broad audience, we wanted to start by looking into the literature to see whether or not there's evidence that they can be effective. And so this is just a meta-analysis that's looking at web-based interventions that were used and demonstrating that there was a significant reduction in LDL cholesterol in studies that are using a web-based intervention versus using not using one. So they can be effective. So if shown to be clinically effective, these health apps or web-based interventions can really help provide an approach with providing the opportunity for educating and engaging patients in evidence-based information to increase the uptake of dietary patterns for chronic disease prevention and management, and provide that platform to integrate strategies for sustained behavior change, support the patient-provider relationship, and then again, like I said, helping for allowing that broad accessibility as well as inclusivity. So we all know that for any intervention to be successful, adherence really is key. But the other thing that we also want to be thinking about is sustainable success. So that's where we've been working on integrating behavior change theory as well as co-design frameworks when we're building our interventions to help with the sustainability. So my student Diana gave you a bit of a presentation yesterday that was starting to talk about the behavior change theory and mentioned the COM-B model, which is a very commonly used one that helps with integrating ways in which we can help people to change because they need the capability to do it, they need motivation, and they need opportunity. So you need all these things to be there to really help with allowing for that sustainable behavior change to occur. And the theoretical domains framework is a set of theories that have kind of been consolidated to kind of more actionable targets across these domains, which are all mapped to the COM-B model to give us kind of a platform to start with targeting different ways that we can be integrating strategies into our interventions to try to help with supporting that capacity, motivation, and opportunity. And so I also mentioned co-design theory, and I'm not going to go into that too much, but it's fairly straightforward, I think, to try to understand. It's really getting everybody at the table at the beginning. So bringing together the patients, the healthcare providers, interdisciplinary teams to really get at the end goal of making something implementable. So making sure all of those are not only integrated in design, but in the design of trials that you're doing to ensure that you can kind of be targeting a lot of the outcomes that branch patient-facing important outcomes, healthcare provider-facing important outcomes, and things that help with policy change. And then having credible organizations. We work a lot with the Canadian Cardiovascular Society and Diabetes Canada to be hosting or supporting these programs that we're creating so that it's a reliable source of information to direct your healthcare providers to, as well as patients. So I'll go into the example of the portfolio diet translation tools that we've been developing, and a few of the students have been presenting on it, so I don't think I have to go into too much detail. But just quickly to highlight, we always take a two-pronged approach. One is a lot of medical education does not include nutrition, so we do need to help provide some tools to first onboard the physician and all healthcare providers, because you can have pharmacists now that can be helping with translating these, or nurse practitioners, and then the patient-facing tools, which are much more extensive. So the healthcare provider-facing toolkit, Gabby presented earlier this morning, and we recently validated that, and it's currently under review at the Canadian Journal of Cardiology. And so with that, we have a under 5-minute little video and an infographic. So if they don't want to read the infographic, we have the video to help support that. And in our validation study, we demonstrated that in a diverse group of healthcare providers that serviced a variety of population types. We asked them about who they service. They indicated that it did increase their knowledge and confidence in recommending the portfolio diet, as well as the portfolio diet app, which I'll get into soon, as the tool to help with engaging their patients, as well as increasing their confidence in recommending the toolkit to other clinicians. So this is what the infographic looks like. And there's a section there on the patient-facing tools. And so those are available on the Canadian Cardiovascular Society website. The patient-facing one is there already. The healthcare provider one will be there soon. So if you look at the patient-facing infographic, this is something that can be easily a handout at the doctor's office or anywhere. There's the QR code and the app that will bring you into the portfolio diet program. So the app forms the basis of the program. It's not meant to be something that somebody has to use every single day for the rest of their life. It's more just that initial part that helps to start getting them engaged. So I'll go over a little bit about some of the features of the app, as well, just quickly highlighting the Kickstart package, the text messages, and the 16-session online curriculum that map out to a 12-month program to help support the education and engagement of sustained change that can help with translating the portfolio diet. All of it integrated and mapped to behavior change theory. And this is the kind of just little highlight of the co-design and the team that's involved. So we have a variety of features that are in the portfolio diet app. So different things like tracking, goal setting, a leaderboard and gamification, a variety of things. And again, all of them are mapped to the theoretical domains framework. So this is the dashboard. It's meant to not be a diet tracker, but something that you're just trying to help with engaging people in understanding, and they can be tracking their consumption of foods that align with the pillars of the portfolio diet. So each pillar is given a set of 5 points that they can reach per day that align with the recommendations. And this is the validated score, the clinical portfolio diet score that Megan Kavanagh validated recently. So the overall target is not perfection. We're not going for 25 out of 25 points. We're going for 12 out of 25, because in the dietary advice trials that were previously done by Dr. Jenkins, 50% adherence results in a clinically meaningful reduction in LDL cholesterol between 10 to 15%. So you can help support your patient with a feasible and achievable goal. And if they want to continue on, they will see more and more benefit, because adherence is linearly associated with greater reduction. There's also the gamification. So we have quiz questions. And so it helps them with feeling like they're having a little fun with it, getting stars for being able to answer the question correctly. And if not, again, it's helping with reinforcing education to build on that knowledge. They can enter information to calculate their Framingham risk score, and they can enter how they're changing or tracking their health measures. If they're interested in their blood pressure, or if they're interested in their cholesterol, they can use this to enter. It'll graph it, and then there's a print button so they can share it with their healthcare provider. We've got a variety of resources available on the website as well. So we have a variety of tip sheets, not only just helping to educate on the pillars, but also thinking about budgeting, if there's budget constraints, any other like special considerations, if there's allergies. Even if you have an allergy to a nut, it doesn't mean you can't follow the portfolio diet, but there's guidance to help with navigating different types of allergies, as well as fiber and bloating, because the portfolio diet is high in fiber. And then there's a lot of videos that help, and we use different types of videos. So whiteboard videos, if people kind of like that type of modality, or if they like those nice little in-kitchen demos of recipes. So we have a very large recipe bank, and this is something that we do in collaboration with the George Brown Culinary School down the street from us in Toronto to try to help with designing a lot of different types of recipes that meet a lot of cultural needs. This is just to show you what the text messages look like. The online Kickstart package is a daily email that's sent out that's kind of like little sound bites that they can get every day to just slowly onboard them with information so that it's not kind of overwhelming to try to go through everything in one day. It's something that, we can guide them through. I'm not going to go through the online behavioral curriculum because yesterday Diana gave you a presentation on the way in which we're integrating the behavior change theory across of it. And Vivian just this morning was kind of giving you the really nice, beautiful pictures of all the different ways in which we're using the online articulate platform to try to help with engaging them with testing their knowledge, providing little case scenarios so they can see what it's like if somebody's having a challenge with something. So building in like problem solving through a case video series. So that's kind of just a bit of the design. And now we've done quality improvement assessments to get into the communities and see what they think about it. So we particularly work with high risk communities, high risk of cardiovascular disease and diabetes, and that are very ethnically diverse. So Gabby ran a two-phase quality improvement assessment of the portfolio diet program in the community and demonstrated that in the 63 participants that joined, 49 of which then completed focus groups, 87% reported an increase in knowledge of the portfolio diet, and we use a validated score to demonstrate usability, and in the end it did demonstrate good usability. One feature that was highlighted that needed maybe a little more work was cultural relevance of some of the recipes. Specific ethnicities were highlighted. So we worked with the community to submit recipes that are their traditional dishes, and we worked with them to try to make it something that could align with the portfolio diet and then put those back up onto the website. We also did subgroup analyses, which by sex, gender, and social determinants of health did not reveal any difference, with the exception of education, where those with lower education reported greater usability. And with that, we think that people that are highly educated probably have higher expectations of what a very simple app that's just supposed to help you engage with learning about a diet is really meant to do. And that was work that was led by Queenie. So this is informed modifications, and phase 2 is underway as we speak. So the portfolio diet program is going to be tested. So we're now assessing its implementation in 3 randomized controlled trials and 1 implementation study. The CHEAP trial, I'm going to actually show you one slide of in a second, but the switch trial, Antonio presented yesterday, and I presented the repair trial when we were talking about remission. So the switch trial is demonstrating how actually a DASH enhanced version of the portfolio diet program can be effective on helping with additionally adding those pieces from the DASH to help with blood pressure reduction, as well as looking at LDL cholesterol and HbA1c in the 300 adults with hypertension and obesity, 50% with type 2 diabetes. And then the repair trial is leveraging the portfolio diet program to help with the weight maintenance phase of the plant-based intensive lifestyle intervention for diabetes remission. So the CHEAP trial is a CIHR-funded study that will look at the effect of the portfolio diet program added to standard of care versus standard of care alone. First looking at achieving lipid targets at 1 year, and then going out to 7 years to look at major cardiovascular events. And this will be in 1,100 adults at high risk of cardiovascular disease through primary care. And this study is currently underway. So now just quickly a little bit about the next program that we're working on, which is translating glycemic index. So Queenie presented a bit of this to you already. So this is our team. These are all of our interest holders that are involved. So we predominantly are working with Diabetes Canada and Diabetes Action Canada, which really help with bringing in a lot of patient partners. This is quickly just the dashboard of it, and it includes a lot of the same features that are in the portfolio diet program. One little addition that I'll put in here is some of the upcoming things that we have going on for both the GI and portfolio apps. It's another phase of work Queenie will be leading, and this is in collaboration with Dr. Mary LeBay, where we're generating or creating nutrient profile models for both glycemic index and the portfolio diet. So layering in things like where there would be a product that might have a front of pack label on it, a warning label that would not be recommended as a food of choice. But creating those nutrient profile models, validating them, and then integrating them into the Flip database so that we can integrate a barcode scanning feature into the app so that if they go to the grocery store, they can scan a food and it can help them with selecting foods at point of purchase that align with either of those diets. So in conclusion, effective and inclusive interventions can be designed to help translate therapeutic dietary patterns into practice because mHealth apps do have the potential to really help us with that education and engagement piece for patients to increase the uptake of our dietary patterns and supporting sustained change while also supporting patient-provider relationships, accessibility, and inclusivity. It's important to design and evaluate them using co-design frameworks to include everybody's important perspectives, not just my perspective, but the community that it was the target audience of it. And it's also important to also reflect on integrating the values, preferences, and treatment goals of the audience, the target audience, to ensure greatest adherence over time. And as I mentioned, the two upcoming tools, they're both freely available and you can create an account. There's a gatekeeping step. So if you try to create an account, we get an email just to make sure that you're a real person. So we'll email you before we then activate it. So with that, I thank you. I thank my team and everybody because they do a lot of work to get all of this going. And yeah, thank you.
Thank you very much, Laura. This very nice and clear presentation. Now we move on. Andreas will present the next speaker.
Yeah, it's my pleasure to call Benoit Lamarche to the stage. He's professor at Laval University in Canada, and I had the pleasure to be seated next to him, so I learned a little bit about him. And he will be talking to us about unlocking the potential of AI to better understand dietary patterns. So the first event on AI here.
Yeah. Thank you so much. And I extend my thanks to the organizers for the invitation, my second appearance. So I guess I can apply for membership now. Yeah, I realize everybody's exhausted cognitively after 3 days of amazing conferences. So I figured that would happen. And to help me as well, I kept it very simple. AI is a huge field, many examples, many potential, a lot of research in this area. So I'm just going to give you a glimpse of what we can do in trying to understand dietary patterns using one AI-based method. These are my disclosures, mostly funding from government and national funding agencies. So the challenge we're facing, and we've discussed that throughout the last 3 days, is how do we measure this? This is what people are exposed to. You might have seen these slides in the past where they have put the traditional foods of different countries on one table, and the challenge is measuring this the best way possible from a diet quality perspective, but also from a dietary pattern perspective, because people eat these foods in different ways and at different times, and that may actually become a factor when we are interested in trying to understand the relationship between diet and health. So there are different ways at measuring dietary patterns. You can use a priori approaches where you basically have scores and you score the diet according to these metrics that you have decided a priori, a med diet score or healthy eating index score. So you just decide how to use the data. And then there's the other approach, which is the posteriori approach, where you just decide you let the data decide what it looks like, essentially. So there's the classical principal component analysis approach, or more sophisticated and more recent AI-based methods. So I'm going to give you an example of one approach based on AI that can actually provide information to which we didn't have access using more traditional data-driven methods. So one of these methods, and I hope this is the updated presentation, is it? Yeah, okay. So one method is based on basically statistics, but also machine learning in the second phase. So one method is based on the Gaussian graphical model approach, where you basically correlate all the food groups that someone eats or a population eats, and define basically a matrix where all the foods are correlated, but the correlations are partial. So they're adapted and adjusted for each other in the matrix. So you get a whole series of correlation between the foods that are reported together, either in a food frequency questionnaire or in a 24-hour recall. And that creates a whole matrix of correlation of the different foods that people consume. You can then use, so this is based really on statistics because it's just correlation, partial correlation. But then you can use other approaches that are machine learning based, where you address the structure of the correlations between the different food groups. So one of these algorithms is called the Louvain algorithm, and it basically tries to define the modular structure of the correlation between the different food groups that are reported together. And it's very similar to analyzing a social media structure. In a social, not social media, but a social structure of a network. So in a network, you have people that are very influential and have a lot of connection to other people that are influential, and these people have a lot of influence on the network, on the social network. So it's the same for food. So the foods that would be connected to other foods, and therefore that are more often consumed together, are more influential in the dietary pattern. And so you can get at different communities of food that appear more often together and that are correlated, partially adjusted for other foods, more or less. And so you have a lot of strong connection and more sparsity between different food groups. And you can then define these communities based on, okay, these are the foods, for example, that are mostly healthy. So this is a healthy community of foods. And this is a structure I see in one group, for example. So, and I believe this is the previous presentation, but it's okay. We'll keep it at that. So just an example, we used this approach in a database we have in Quebec City on dietary habits in adults in Quebec. And so we took so we measured dietary intake by 24-hour recall, repeated measures, and we correlated 40 or so food groups from those 24-hour recalls, partially among each other, and came up with food group communities that were just naturally related to each other and were strongly or less strongly correlated to each other. And the idea in this example is, are there differences, for example, according to age or sex, which has been studied quite extensively, but in this case, according to sociodemographic characteristics, and we use material deprivation, which is a measure not of the individual challenge in terms of socioeconomic status, but the environment in which they live. And the idea is, if there are differences in the structure of how the foods are correlated or consumed together between groups, then that might inform possibly interventions in different ways, depending on how the structure of the dietary pattern appears. So in those that are not don't live in a material deprivation area, you have a specific pattern of a relationship between different foods. This is too small, so I had some changes in my slides, but this is not important. So the idea is, if you look at those that are more privileged or those that are less privileged, the structure of the foods that are consumed, and therefore the relationships of the foods and how they're consumed or reported in 24-hour recalls vary. And some foods are strongly correlated in a specific group of the population. They're not less so correlated in the other group of the population. And that might be useful in better understand what are the challenges in for example, a lower socioeconomic population. So this is really different from PCA, for example, where you just let the data and then data run and see what the patterns come out. But you can really get at more nitty-gritty relationship between food groups within different groups of the population. So what's interesting with this approach is that you can then use this understanding of dietary pattern and try to see whether this informs outcome in a population. What we did is we worked with our colleagues in France who run the Nutrinet Santé cohort. It's a huge cohort in which they have measured dietary intake with 24-hour recalls on repeated years, repeated times every year. And they have very, very fine and detailed assessment of outcomes and dietary intake data. So this is a graphical, Gaussian graphical model results. Basically, there's, again, 45 or so food groups that have been identified. And this is the partial correlation of all the food groups together. You can't see much. But if it's a red line, it's a negative correlation. If it's a green line, it's a positive correlation. So some foods are more strongly correlated with others. Other foods are not correlated at all with others. And this reflects how foods are consumed in a population. So and that's an important point because each time you run a model like this, it's population specific. So if you identify diet structure or dietary pattern structure in France, they're not going to be the same in Quebec or in the US because this is population specific because these are correlation of the foods people consume in each population. So these become population specific. So basically, you can group the foods that are closer in the network that form a community and of food. So in this particular population, we had 5 communities of foods that were strongly correlated and had a strong relation between each other. And then you give them names. In France, we had the first community, just to give an example, which we call the appetizer foods. So it's, alcohol beverages, basically foods that are consumed at the appetizer time. And this is really typical to the French population. Plant-based foods, for example, which, the foods that were consumed often together and had a strong relationship together in this population, nuts, legumes, plant-based replacements of dairy foods, and so forth. We had sweets and snack, fast food, chocolate, confectioneries, sugar, sweetened beverages. So you describe the dietary pattern, and this, if you run this again in Canada, you would probably get different results. So what you do then is you apply the Louvain algorithm, and you can actually, within each community, you can score adherence of each participants to each pattern of or each community groups of food. So a participant that would have a very high consumption of the foods that are in the yellow community, you can ascribe a score that's higher, and you can do that for each of the community groups of foods. And so you use, for example, what's called centrality values. And again, it's really similar to what we do for social network analysis. And eigenvector centrality, for example, a high value reflects how influential is a node, here a food or a person in a social network. Is it connected to many other foods? And are these other foods connected to many other foods? And that would give this particular food a high eigenvector centrality value and so forth. So you can actually get at scores of adherence to each of the community foods and get then at associating adherence to each of these patterns to health outcomes. And so we did that in the Nutrinet Santé cohort, and I'll just give you, so we have 5 communities of food, so 5 network of foods within the big network. And interestingly, a high consumption and therefore a high adherence to the consumption of sweets and snacks in the French population was associated with a higher risk of having cardiovascular disease. The other patterns of consumption were less strongly associated with coronary heart disease. This is the association between adherence to these patterns of consumption, but adjusted for overall diet quality. So on top of everything else, if you adjust for diet quality, those participants, the French participants who had a high score and therefore consume a lot of these sweets and snacks together and report these snacks together in their 24-hour recall are at high risk of cardiovascular disease, independent of all other measures of diet quality. And so you run an analysis like this in Canada, you might see a completely different result, but this is really specific to that population. And it does point out to where maybe we should look at more specifically in different populations to address the main dietary challenges in terms of health outcome. So take-home messages, I promise I would keep it simple. So these methods are extremely exciting, they're promising, they're new. One of the and we're going to learn a lot of new things about dietary patterns using these measurements. But these are different examples. So the ones I presented is the one in the middle there, but there are many other possibilities that we can use to unlock and understand dietary patterns. And this might give us a new perspective also on the relationship between diet and health. So of course we know what the big nuggets are in terms of diet and health. It's fruits and vegetables, whole grains, less ultra-processed foods, and so forth. But the structure of the consumption might reveal new things that we didn't know. Again, I emphasize all of these methods are population specific. So a pattern that you reveal in France, you cannot translate that to another pattern in North America or Australia. By luck, it might be the same, but it's really population specific. Now, one thing we're going to be challenged with in 2, 5, 10 years is using these different methods and trying to make sense of all this, for example, in a meta-analysis. Because then these become population specific, they're method dependent, and actually this is something I didn't mention, but the Louvain algorithm is tricky, and if you run it 10 times, you might not always get the same answer. So that's something sometimes you don't hear about AI, but that's one of the challenges we have because the models are not so stable. And we still have to refine all of this knowledge of using these these new methods. So, but it's promising, and we're going to be seeing more and more of these things. So we should look forward to seeing how it's going to help us improve our knowledge of diet and health. And I'll be for sure looking to that as well. So. Thank you to all my colleagues and team and the Nutrinet team, of course, with whom we collaborated for this. This is, I guess, one of the most important slides of my talk. This is my team at this time of my career, and I'm very privileged, and I'll look forward to the discussion. Thank you.